So my name is Amanda Sandoval. I am the Director of Communications and Prevention Services for High Point Treatment Center. And today's webinar is Strengthen the Community Behavioral Health Resources on Suicide Prevention. High Point Treatment Center offers the full continuum of care. We have 24-hour level of care admissions. We have inpatient services such as detox and step down. We have outpatient services with open access. We have residential programs for men and women. We have a healthy families program. We have shelter services for families, community-based services, prevention services, as well as domestic violence and victim services. So High Point Treatment Center does their best as an agency to fill any of the gaps and the needs in the community. And today we're going to highlight two of the programs that fall under our CBHC, including our ACCS unit and our mobile crisis unit. And I'm going to pass over the mic.
Hi, I'm Shiva, the Director of Mobile Crisis with High Point in Brockton. I think you can, next slide, yeah. So there are a few ways to access some resources. There's state and federal resources. The Massachusetts Behavioral Helpline is one option, 24/7 support, call or text anytime. Anybody can call for any reason. It's more warm line support, depending on what's going on and if there's any safety concerns or if, someone is expressing suicidal ideation. To our team will it's available at any time. Anybody can call the HL. The suicide crisis line, it's just 988. You can call from anywhere, anytime, same kind of situation. So at any time, if anyone's feeling we have the CBHC. The CBHC is basically a one-stop shop for all types of interventions. It's statewide. So there are different CBHC centers in different catchment areas throughout the state. Brockton is one hub of CBHC, and that is through us at High Point Treatment Center. They offer immediate care for any mental health or substance use disorder or co-occurring disorder. 24/7, 365. Included in the CBHC are the crisis services, which I will talk about a little bit more. Also the CCS services, which Elaine will talk about as well. But as well as crisis and the community crisis stabilization is outpatient clinics, full range of comprehensive treatment, usually with extended hours, open from 8 to 8. You can come in, walk in, or, call, request help. They can be seen urgently. Different types of service provided could be in person or virtual. Immediate mental health and substance use service. sometimes individual and group therapy. We can do psychiatric medication consultations, peer supports, medication for addiction treatment or MOUD treatment can be offered as well, and other referrals. So the CBHCs are set up to be a one-stop shop for anyone seeking some sort of mental health or substance use support. They can be called or, just easily accessible is the point. Can call or walk in or call your crisis team and we'll help you get connected. And that is for both youth and adults. So mobile crisis intervention, we are a service connected with the CBHCs. So all the CBHCs will have a mobile crisis. There will be a mobile crisis in every catchment area of the CBHC. So again, we are in Brockton. That is this catchment area's location. Mobile crisis is immediate support for any crisis or behavioral assessment. Could also be for substance use, immediate need assessment. Services are 24/7, 365, ages 3 and up, so youth and adults. Anybody can call at any time and request service. We're located at 10 Meadowbrook Road in Brockton. The best way is to call our call center, either the local number, the 508-580-0801 number, or there's the 800 number, and that'll connect you immediately to a clinician that will triage, and we will come out and see you. We can also do walk-in or telehealth. So yeah, next slide. So we serve adults and youth. So adult crisis. Basically, adults for us is anyone 21 plus. Again, 24/7, anyone can call at any time. We can assist, do an immediate evaluation, and determine the best level of care and support. It doesn't matter what the, issue is. Anyone can call and we will assist. We can do an evaluation. We like to do an evaluation within 1 hour. Sometimes we can do sooner depending on just the staffing pattern we have of the day, but we can provide up to 3 days of follow-up after we see an adult. So we can do our evaluation and then we can do 3 days of follow-up for any adult, just to help with any referrals or care coordination or ongoing support that might be needed in that 3-day time. So crisis services are very brief, but complex. We do help with many things, care coordination, referral, and we, the quick, but we do a lot in that short period of time. And we have master level clinicians, bachelor level clinicians, and a family partner on the team. So there's a range of support that can be offered through crisis. Next slide. And again, we also serve youth, youth 3 and up, really. So that is, 0 to 20. A youth is considered someone up to 20 years old. Same situation, anyone can call, a guardian could call, DCF could call, so anybody could call. A youth could call for themselves, and we're always going to try to help the best we can. Our goal of crisis is to keep people out of the emergency room. We want to be able to help you in the community. So that's our goal, to be able to help you right away and do our evaluation in the quickest and, more convenient way possible for you. So for youth, we can provide 7 days of follow-up after an evaluation. And during that time will be care coordination, support, maybe some safety planning meetings if the youth is already involved in some other services. We can spend some of that time coordinating with the other services, sharing treatment plans, safety planning. So, yeah, that's available. And the same teams provided. We have master level clinicians, bachelors, and family partner that can help with any of those situations. So yeah, just call. Next slide. Yeah, so mobile crisis, we can see you in any capacity that works for you. We can come to you wherever that is. It could be the school, it could be home, it could be a doctor's office, it could be, court, wherever. You could also come on site and see us here. You can walk in at any time and we will see you. We can also do telehealth. So if you call, we'll always offer those 3 locations and have you choose what is best for you. And then we will do our best to accommodate that. And next. Next slide. Yeah. So sometimes people think you have to be always in crisis to call crisis, which is true. Like you can call when you're in crisis, but you could also call anytime. Sometimes you could call because maybe a crisis could be potentially starting. Someone could be a little bit off their baseline, but maybe don't need a full evaluation right now, maybe just a consult, or maybe, just not sure what to do, want to touch base with someone, get a little warm line support. So we can be accessed, you can call for any reason. It doesn't always have to be because you want a full evaluation. Sometimes it could just be, just someone to talk to briefly, something like that. We can do some pre-crisis work. Sometimes, for example, a school could call and have us come out to a school meeting, or, we could sit on maybe a meeting with DCF or DMH and do some crisis planning or, safety planning meetings so we can coordinate. Sometimes, yeah, sometimes someone just needs to talk to someone for a minute and we can do that. So we can do, any kind of warm line support at any time. So it doesn't matter what the reason, we're just here. We're 24/7. Anyone can call at any time for any number of reasons. So, and we are insurance blind. It doesn't matter what insurance you have or if you're uninsured, you will be seen. So, yeah, we take all insurance and no insurance. So insurance should not be a factor in calling crisis or not. We'll always find a way to help you regardless of the insurance. Especially if there's safety concerns, anyone should call at any time. Don't let insurance be your barrier. Next. And just to mention, we do bill insurance, but we're not going to not see someone because of insurance. So just there's that. We will bill if you have it. But I don't want having no insurance be a barrier to accessing the service. So our process is you will call, we will most likely do an evaluation. We'll do a full evaluation, screen for any safety concerns. Clinicians will do a thorough, history of psychiatric. They'll do a thorough suicide screening. sometimes homicidal screening. So we'll do a full assessment. Depending on how the evaluation goes, they will recommend a treatment or a disposition. And then we will make the referral to the appropriate place. So whether that's doing outpatient therapy, whether that's doing a partial hospitalization treatment, or whether that's going inpatient, we will make that recommendation and we will do the referral. That's partly why we do some follow-up so we can, connect the services and make sure you get the service you need. We will follow up with you until that place is secured. So, yeah, so, we have the ability to also send people directly to an inpatient setting as well. So any type of recommendation we will do. So next. Oh, great. And that is it for mobile crisis. Yeah, and just, always call is the answer if there's any suicide ideation of any sort, or even if you're calling on behalf of someone, it's better to call than not call. So we'll always find a way to support or make a referral or send, whoever it is, make sure they're safe. That's what we care about, is people's safety. So that's it for mobile crisis. I'll pass it on to Elaine.
Thank you, Shiva. Hello, everyone. My
Welcome.
name's Elaine Thomas. I am the Program Director for High Point's Adult Community Crisis Stabilization Program. As Shiva mentioned, we are also part of the CBHC for High Point. We work hand in hand with Crisis Center. And we are a 24-hour staff secure program. It is not a locked program. It's a voluntary program. It's short-term stabilization. Typical stay is 5 to 7 days, typically. So we take referrals 7 days a week, 24/7, 365. And referrals come from either emergency room settings, step downs from inpatient psychiatric facilities, or from mobile crisis intervention services. It does not have to be. We take patients from all over, from various mobile crisis intervention services as well. And all of our referrals go through our central intake, and then we review them from there. Next slide. So we are a Department of Mental Health licensed program, and we have recently received a dual license by Bureau of Substance Addiction Services, BSAS, to provide detox services for patients with significant co-occurring needs. So the idea is patients still require a primary mental health diagnosis, but if they have underlying substance use co-occurring and we have concerns about perhaps withdrawal, then now we will have the medications available on hand to make sure that the patient is safe and comfortable. So, and these would be patients that would not require like a full detox admission. Again, the treatment setting is voluntary, and it is meant to divert from emergency rooms or inpatient psychiatric hospitalizations. Next slide. So we do a thorough evaluation. We have a multidisciplinary team that consists of mental health specialists, clinicians, nurses, recovery specialists, psychiatric NPs, and we have supervisors for all of the disciplines. So we're a multidisciplinary team, a very robust team, and the patients are assessed. There's a psychosocial assessment. They're risk assessment, a psychiatric assessment, nursing assessments. So a full assessment when the patient comes in, including for suicide, the Columbia Suicide Assessment as well. Even though patients coming in have already had those assessments, we provide those as well. And we have group treatment. We have a group schedule. We have group treatment. Very important is aftercare. We have aftercare clinicians who begin the disposition planning right when the patient comes in, again, where it's short term. We also have the peer specialist supports that help as well. Some of our patients discharge to home to partial hospital programs or to outpatient programs. Some discharge to CSS programs. Some discharge to sober homes or perhaps shelters with case management services. So it's really we have to hit the ground running when the patient comes in as far as where is the patient going to go and what is the safe disposition plan. And as I mentioned, we have detox protocol for co-occurring patients. And so that, that is with the nursing department, and that would be assessed as well when the patient comes in. Next slide. So again, assessment and evaluation by the various disciplines. The treatment plan is developed right off when the patient comes in within 24 hours. We have the milieu-based treatment with the mental health specialists. We have the aftercare and case management that looks at the individualized needs of the patient and their treatment plan and where they will go when they are discharged. And the patients meet individually each day with their clinician. Again, risk assessment and safety planning is always in the forefront. And sometimes we have to issue a Section 12 and involuntary hospitalization if the patient is unsafe, in a voluntary setting. And that's when we would access our psych nurse practitioner clinician. We would meet together with the patient. At times we have to access mobile crisis, which is right next door, our partner. They can also do what's called a direct admit if needed, where the patient doesn't have to go to the emergency room to wait for an inpatient placement. And the MCI team works collaboratively with us to initiate that direct admission. Again, the goal of ACCS is to divert. It's a diversionary program from hospitalization, but sometimes we have patients that come in and their symptoms are just too acute and it's not safe for them to be in a voluntary setting. Next slide. So the outpatient services, so we often can refer our patients to other programs within High Point. Also, so High Point does have outpatient services, but also on discharge, we always make sure that we provide the CBHC that's to the patient's area of tie, as well as the mobile crisis numbers, the area of tie, as well as the 988 and the behavioral health helpline. So we also provide, in addition to their aftercare appointments, we also provide all of that information to the patient. There's also groups with aftercare and the mental health specialist to talk about the various options, and the recovery specialist also attends some of those groups and can refer patients to the program that High Point has, that provides ongoing care in terms of recovery specialists or community support staff. Next slide. Okay, and as I mentioned, we're 24/7. We take referrals. They go through our admissions department, and a patient needs to have an evaluation in order to determine, is this the appropriate level of care? You know, if not, then we would make recommendations to the referring facility. But essentially, they have to either come from an emergency room, an inpatient, step down from inpatient, or from a crisis team. And also, we have patients within High Point in other levels of care that might need to step to this level of care. And again, that would go through our crisis team to determine if that's an appropriate, you know, disposition for the patient. I think, is that the last slide, Amanda?
It is, yep.
Okay.
So thank you, Shiva and Elaine. We wanted to open it up now for some questions. If anyone that are participating today had any questions that we could try our best to answer.
Mm-hmm.
And you can use your raise your hand feature, or you can request to chat. If there are no questions, that's fine too. We will be sending these slides following the presentation. We also will send you a brief survey and a follow-up email, but we appreciate you attending today's webinar, and we hope you have a good rest of your day. Thank you very much.
Thank you.
Thank you.
ACCS